Dr. Kiran, Dr. Santosh join ayyara?
Yes, Santosh is there.
Yes,
Santosh
sir.
Yes.
Okay, yeah.
Good evening, sir.
Good evening, Santosh. This is Dr. Vijay Pastor.
Yes, sir. Yes.
President of IAPM AP Chapter, sir.
Yes, sir.
Just a minute. Please give me 1 minute. I'm just streaming it live in the YouTube. So all the participants, please unmute and also mention your name in the Zoom window. If it's not mentioned, you can go to the Zoom window. The options will be there where you can rename and you can mention your name so that we can know who is participating. Now I'm just doing the process of preparing to live stream this meeting in the YouTube. So it's taking just a few seconds. So that those who cannot join in the Zoom, they can view directly in the YouTube also. Yeah, now it is live streamed in the YouTube. Just a minute. I'm just doing the process of preparing to live stream this meeting in the YouTube. So it's taking just a few seconds. Pause it. Yes, sir. The live streaming in YouTube is over, sir.
Okay.
Just a minute. Copy streaming link. I can just okay. Just a minute, sir. Yes, sir. Now we are starting, sir. We'll start. So, good evening, everyone. Everyone, please unmute their speakers in the Zoom window. Is it visible, sir?
Yes, sir.
Yeah, thank you. Yeah, so as we know, it is an initiative we have taken because now it is the era of all virtual online meetings. We are seeing plenty of these online meetings. So we also thought that our IAPM AP chapter also should take this initiative, even if it is a bit late. We should, but still better late than never. So we have started this initiative with the cooperation of all the our executive board members and also the executive council members. So IAPM AP chapter welcomes all the members of our chapter and also all the participants and all the faculty, all the postgraduates and consultants to this first online scientific session of today. And as you know, the presenter or the speaker of this today's session is Dr.T.Santosh, and he will be speaking on the cutaneous melanocytic lesions, the information of which was given to you already. Just a minute. So just the general instructions. So everyone please set the Zoom settings, the audio settings to mute and video off, so that there won't be any disturbance during this session. And I hope all will cooperate and follow these instructions. And also those who have not mentioned the name while joining the Zoom link, in the Zoom window, the options will be there in the corner. You can click that and you can please mention your name so that we can know who has actually participated. So the name should be better. Also, it will be live recorded and live streamed in the YouTube. And also for later viewing, also we can view. It will be uploaded in the YouTube also in our IAPM AP chapter, channel, YouTube channel. So please mention your name. And any doubts and questions regarding this lecture or any other questions or any technical questions if you have regarding any feedback you want to give to the organizers, you can just type in the chat box. Don't unmute, but please mute. Someone has not muted. So please just type the question in the chat box during the presentation, and that will be responded by the host. And I'm the host of this today's meeting, so I will respond. And the answers also will be given to you at the end of the presentation. Answers regarding this today's session, they will be answered at the end of the presentation. So just type your questions in the chat box. So very good greetings to all from the executive body of IAPM AP Chapter 2021. Just a minute. So these are all our IAPM office bearers of this 2021. As you know, the current year has become null year because of this COVID pandemic. So the same office bearers will continue for the next year. So this has been decided by our IAPM national body, and also it was mentioned in our WhatsApp group also long back. So the same bearers office bearers will continue. Even if those who have 1 year term, they will continue for next year. And this present year will be null and void. It will not be counted. So because of this pandemic times, we know. And also all our executive council members, they also convey their greetings to all the members and participants. So now I request our President Sir, Dr. Vijay Bhaskar Sir, to please address today's session and all the participants and members. Sir, please.
Yeah, thank you, Kiran.
Sir, thank you. Yes, sir, please.
My dear colleagues and postgraduates, good evening, all of you. We are very happy to announce that IAPM AP State Chapter initiating the online platform for the benefit of our members and postgraduates. And I welcome to this first online meeting of IAPM AP State Chapter. As all of you know, the importance of the digitalization in these difficult times, because most of our faculty members and postgraduates are involved actively in COVID management. So for the conduction of the CMEs and webinars, we did a virtual platform like this. So this is just a beginning, and with your cooperation and coordination, certainly will improve this program. And at this time, most of the senior faculty also they have come forward to act as a resource person, and we are trying to make arrangements to conduct the webinars both national and international level faculty members are having rich experience in different fields of pathology. So I request all the postgraduates to make use of this platform and give a genuine feedback regarding the topics so that we can plan accordingly. I thank all the executive members for the cooperation. And also, I invite today's speaker, Dr. Santosh, Assistant Professor of Pathology, All India Institute of Medical Sciences, Mangalagiri, for his topic on cutaneous melanocytic lesions. Dr. Santosh, now I request Dr. Marty to introduce the speaker. Thank you.
Good evening, one and all, sir. I am privileged to read out the biodata of Dr. Santosh Garu. Santosh has his post-graduation from MKCG Medical College, Orissa and DNB, and he has his postdoctoral fellowship in cytopathology from SAIT GSMC and KEM Mumbai, postdoctoral certificate course in dermatopathology from AIIMS Bhopal, sir. He has worked as senior resident in institutes like AIIMS Raipur, AIIMS Bhopal, and SAIT GSMC and KEM Mumbai. Currently, he is working as assistant professor at AIIMS Mangalagiri, Andhra Pradesh. He has more than 70 research articles to his credit in various national and international indexed journals, sir. He is also a reviewer in journals published by Biomed Central, Willy Diagnostic Cytopathology, and Journal of Web, etc. He is a life member of various national and international societies. His areas of interest are cytopathology, dermatopathology, breast pathology, Rose, Jankspear cytology, to name a few, sir. He has keen interest in teaching, active participation in conferences, and delivering lectures. He believes in patient care and better diagnostic facilities. With this brief introduction, I would um, I would thank the executive body for giving this opportunity for me, sir. Thank you, sir.
Thank you, madam. Now we will not take much time. We will go to today's main event, that is presentation of today's lecture, that is cutaneous melanocytic lesions. Now I request our speaker and presenter, Dr. T. Santosh, to please start his presentation.
Sir, kindly permit me to share.
Yeah, sure, sir. Just a minute, sir. I will stop my share so that you will share.
Okay, sir.
Can you share now, sir? Please try, sir. Yes, sir. It was the first time we are also not much aware of these technical aspects. Okay, sir. Thank you.
Sir, good evening, everybody. And we will be discussing regarding common cutaneous melanocytic lesions. But before that, I request all the participants to mute themselves so that there is no intervention during the presentation. And these are the author disclaimers. Author disclaimer, it includes, it is for teaching purpose only. The content shown in the PPT are from online resources and our own experiences, along with proper reference which has been given from the various journals and textbooks, and the authors have been duly acknowledged. We don't have any financial interest or conflict of interest or copyright infringement during the course of the presentation. I would like to acknowledge the organizers of IAPM State Chapter, AP State Chapter. It includes Vijay Bhaskar sir, Kiran Kumar sir, for giving me this opportunity to speak on the topic. I also thank AIIMS Mangalagiri to give me the permission for attending this online series, and AIIMS Bhopal, where I had done the dermatopathology fellowship and got experience in dermatopathology, and my HOD, current HOD, Dr. Arundhati madam, for giving me the opportunity. Coming to the topic of cutaneous melanocytic lesions, as we all know that humans have a various spectrum of skin colors. It can be the light color skin, the dark color skin, the plain freckly skin, and the color of the eyes. But to remember the point over here is all these colors are basically attributed to the pigment melanin. The melanin is classified into two major groups, that is the eumelanin, which can be the dark or the brown black color, and the pheomelanin, which is the red color, which is also seen. The synthesis of melanin occurs through the pathway which is displayed in this picture over here, and I won't be going into the details of the mechanism, but ultimately we should know that the pigments which are formed can be the black color or the brown color pigment which is synthesized, and this is all responsible for the various skin tones in our body. However, the melanocytes are derived from the neural crest structures. So these neural crest structures are the structures which are also responsible for the development of the pyometer, arachnoid, the swan cells, the cochlea, the iris, and some other tissues. So the function of melanocytes is basically for the synthesis of pigment, melanin. These melanocytes are usually located at the junction of the dermo-epidermal region, and these are slightly lower in location compared to the basal keratinocytes. These are the basal keratinocytes which are seen, and the arrow is highlighting the melanocyte which is present. These melanocytes are usually having a clear cytoplasm, round to oval cell, and bland nuclear features. These are also known as the cells of mass. We should remember that the ratio of keratinocytes to melanocytes is usually 1:12. So we will be expecting approximately 1 melanocyte per 12 keratinocytes. This is the hyper picture showing the melanocytes. These are the melanocytes which are located. The melanocytes usually process a dendritic process. These dendritic processes can be identified by the use of special stains such as the Mason Fontana. So the Mason Fontana will be able to identify the cytoplasmic or the dendritic processes which can be. Okay. Before we go to the discussion regarding the pigmented lesions, the types of biopsies which can be received in the pathology department for reporting includes the incisional biopsy or an incomplete biopsy. This incisional biopsy or incomplete biopsy is the cause which should be avoided because these usually false staging of the tumor. The ideal biopsy which should be received in the lab is an excisional biopsy or a punch biopsy involving the whole of the tissue, and a safe biopsy which can also be given, but the safe biopsy should also be a reversible biopsy. Sir, I think somebody has not muted and it's okay. So the biopsy which is obtained is usually received from the long axis along the direction of the eclipse. So the eclipse biopsies which are received are usually shown in this picture over here, which is an along the long axis of the body. So the biopsy is received, and while the biopsy is received, we should always photograph and record the details of the process. So it includes the measurement of the lesion, which includes the length and the width. It may be in centimeters or millimeters, whether the lesions are symmetric or asymmetric, whether the borders are irregular, whether there is any variegated appearance in the color of the lesion or the type of color which is present. If it's a blue color, gray color, white color, or variable color, and type of the lesion, whether it's a nodular lesion or a flat lesion or a macular lesion. Okay, so these are the different types of recordings should be noted from the biopsy in gross specimen. And if you see the biopsy picture which is shown over here, the superficial biopsy is just like a safe biopsy, which is incomplete, and the primary lesion which is located in the deeper tissues cannot be received. As a result of which, it will cause false staging or false grading, and it should be avoided. And this can be avoided by the use of excisional biopsy, and the excisional biopsy should be a deep excisional saucer biopsy so that it includes the whole of the tissue which is required for the investigation. The specimens which are usually received in the lab should be surgically inked. So the inking is very important because it will help us in identifying later on during the reporting. And the section should be taken through the thickest area of the smear. So we can see that if it's an eclipse biopsy, the thickest area and the darkest area is the most important area which has to be taken, and it can be divided into two equal halves at the point of the darkest area, and following which the rest portion of the tissue can also be divided into equal halves. That is known as the rule of two halves. We should note that thickness should be approximately 2 to 3 mm intervals so that we are not missing out any satellite lesions. So that's an excellent article which is available on the net regarding the guidelines for the management or handling of melanocytic lesions. So this article has been referred to during the course of our The criteria for melanocytic lesions, the most important is the age of the onset. The age of the onset, it is usually a congenital lesion or an acquired lesion. So the age is also an important criteria. The size of the lesions, we should remember that melanomas usually are more than 6 mm in size, whereas there are exceptions when there is a small melanoma which is less than 4 mm in size. Similarly, we have the congenital small nevus which are less than 1.5 centimeter, or the medium-sized nevus which can be 1.5 to 20 centimeter, or the large congenital nevus which are more than 20 centimeter. And sometimes there may be the garment trunk nevus or the bathing nevus, which is like extending through the whole of the abdomen and the trunk area. These are the sizes of the nevus which can be encountered. Location wise, this can be located in the acral area, this can be located in the mucosal or in the genital area. These are the various anatomic locations of the lesion. And the appearance. So we had already discussed whether the lesion is metric and circumscribed, whether there are any macular, papular, or papillomatous appearances of the lesion, or if the color of the lesion is variegated. That is, it is having fuzz colored, tan colored, and various other colors. So apart from that, under the microscope, we have to look for the location of the melanocytes. So the location of the melanocytes can be superficial or it can be deep. So the superficial is the location if it is in the epidermis. So this is our intraepidermal lesions, or if it is in the papillary dermis, or it is in the upper half of the papillary dermis. So these are the areas which are known as the superficial, and the deeper includes the areas which are below it, and it includes the deep reticular tissues and the subcutaneous tissues. So we have to identify the location of the melanocytes. Then the type of melanocytes, whether they are located along the basilar region. So these are the basilar region, which is the region which is shown over here. And it may be in a pagetoid pattern. If the cells or the melanocytes are spreading in an upward direction, we call it as the pagetoid pattern. If it's a nesting pattern or the tumor cells are located at the dermoepidermal junction in a nest-like pattern, we call it as the nesting. And the lentiginous is when the tumor spreads or the nevus cells are spreading in a linear manner along the stratum basalis. Then comes the dermal lesions. These dermal lesions can be again of various patterns, and there is maturation or differentiation. Now, what do we mean by maturation or differentiation is if the lesion is having the grades of the types of the nevus cells, which are the type A, type B, and the type B cells, which I will be discussing in the subsequent slides. Next, coming to the deposition of melanocytes, whether the melanocytes are located in the epidermal surface are restricted to the verrucous projections itself or to the papillomatous projections, but they are not extending deep into the tissues. If there is any stromal alterations such as desmoplasia and myxoid alterations, if there is any features of tropism. So the tropism includes any association or proximity to the neural tissues or to the vascular tissues or to the adnexal tissues. So we call it as the tropism. Then comes the type of cells. So the melanoma cells or the nevus cells or the melanocytes again can be of various types. It may be the round cells, the balloon cells, plasmacytoid, signet sink, the epithelioid cells, the fusiform or the spindle shaped cells, and so on. So these are the morphologic features which can be noted and it should be reported under the microscopy. Apart from that, the three important findings which has to be looked for is the presence of microsatellites, satellite metastasis, and in-transit metastasis. So what do we mean by microsatellites? So whenever there is a tumor which is or a nevus or a mole which is located, and there is one satellite nodule, but the distance between these two is at least of 0.3 mm. So if it is 0.3 mm or more, and we have examined multiple sections in order to exclude the fact that there is no continuation between these two lesions, we call it as a microsatellite. Similarly, if there are satellite metastasis, so that's a lesion or a nevus or a mole or a melanocytic lesion, and there is one more lesion. These two lesions are discontinuous from each other but are within 2 centimeter radius. So they are, if the primary lesion, say the subsequent lesion is within 2 centimeter of the radius, so we call it as satellite metastasis, and it should be located in the cutaneous or in the subcutaneous plane. Next comes the in-transit metastasis. What happens in in-transit metastasis is there is a lesion and there is another satellite nodule. The distance between these two is greater than 2 centimeter, but the whole thing is in the region of the same lymphatic drainage. So if suppose the inguinal lymph nodes are the draining areas and there are two lesions, this is the lymphatic drainage is the common for both of these, but the distance between these two nodules is more than 2 centimeter. So it's called as the in-transit metastasis. So these are some of the features which has to be located or identified during the grossing, and it can be identified with the help of deeper sections so that we are able to exclude that there is no continuation between the two lesions. Now coming to the type of cells which can be seen are the melanocytes, the pigmented cells. It can be the nevus cells or the melanoma cells. So the melanocytes, as already discussed, they have cytoplasmic dendritic processes. These melanocytes are usually solitary and single in appearance, with bland nuclear features and rare mitosis. Whereas the nevus cells are round to spindle shaped in appearance. They are arranged in clusters. This is most important. The nevus cells are nothing but the modified melanocytes. They are slightly more spindle to epithelioid-like appearance, and they are arranged in clusters. So this is how a cluster of nevus cells will look like, and it is known as the nesting pattern. When the nevus cells are arranged in a nest-like pattern. Then we have the melanoma cells. The melanoma cells are highly pleomorphic. It may be round, spindle, or bizarre looking with the presence of significant mitosis and nuclear reticular, as seen in this picture. So coming to the maturation phenomenon, which is seen in cases of nevus cells, is identified in this picture. There are three types of cells. The first is the epithelioid cells. The second is the lymphoid type cells, and the third is the Swannian or the neural differentiation cells. So the differentiation or the maturation occurs from the epidermis. Near the epidermis and in the papillary dermis is the cells which are known as the epithelioid cells. So these are the epithelioid looking cells which are slightly larger with abundant cytoplasm. But as we go into the mid reticular dermis, the cells are more rounder, smaller with scanter cytoplasm. So it's called as the lymphoid type of differentiation. And by the entry into the deeper reticular tissues and subcutaneous tissue, we have the Swannian differentiation, or the waviness of the cytoplasm can be noted. So that is how the maturation occurs, and the presence of maturation is a feature in favor of benign. Next, coming to the markers which can be used apart from the HND routine staining, which is the gold standard for melanocytic lesions. The markers can include Masson Fontana and the melanin bleach. These are the special stains which can be done. And you have immunohistochemical markers. The immunohistochemical markers, most common and routinely done is S100. This is highly sensitive for melanoma, melanocytic cells, but it is not specific. As a result, there are other cells such as the neural differentiation, the lymphocyte, the adipocytic cells, the chondroid differentiation, and the Langerhans cells, which can also be positive for S100. So it's not specific. Similarly, the specific markers for melanoma can be HMB45, Melan A, microphthalmia transcription factor, but they also again are not sensitive. That's the reason they are also in a situation of doubt. We have the SOX10 marker, which also is not much sensitive, and there are proliferating markers, which are Ki67 and P16. So the reason of using all this panel of markers is it can be used in combination. That is a use of S100 along with HMB and Ki67. So these three panel markers will be helpful in identifying or differentiating a nevus from a melanoma. So coming to the differentiation between a benign melanocytes and the melanoma cells, it can be seen in this picture over here. If we draw a straight line, and this is the area towards the left side, which is the benign cells, and these are the malignant melanoma cells. And if IHC is done with HMB45, we can see that HMB45 is diffuse intracytoplasmic positivity is noted for the melanoma cells as compared to the benign melanocytes, which are faint or negative. So we will now move to the disorders of pigmentation. The disorders of pigmentation can be hypomelanosis or hypermelanosis. So hypomelanosis is when there is either reduction in the number of melanocytes or the reduction in the melanin pigment. So here, these are the group of disorders which can have a reduction in the number of epidermal melanocytes and melanin, which includes vitiligo, The chemical exposure to various lotions or skin creams, it can be due to burns, and it can be also sometimes due to hyalonevus and scleroderma. Whereas there are conditions where there is slight reduction in the epidermal melanocytes with markedly reduced intraepidermal melanin. This is predominantly located in cases of albinism, post-inflammatory hypomelanosis, tuberous sclerosis, malnutrition, and so on. So these are the entities of hypomelanosis. But today's point of discussion is more focused towards the hypermelanosis or hyperpigmentation. So the disorders of hyperpigmentation. The disorders of hyperpigmentation can involve the epidermis, it can involve the dermis, or it can be both in the epidermis and dermis, or it can be due to various other chemicals. So the disorders which are involving hyperpigmentation and are seen restricted to the epidermal region can have diffuse hypermelanosis. So the whole of the epidermis is diffusely involved in conditions of systemic diseases, and Graves' disease, myxedema, malnutrition, chemotherapeutic drugs, etc. Whereas there is circumscribed hypermelanosis, or there is a localized area of hypermelanosis, which is seen in conditions of freckles, capillary spots, lentigo, melasma, and Becker's nevus. So these are some of the conditions where there will be circumscribed hypermelanosis. Then there is the condition where there is increased melanin, but it is restricted to the dermis, and it is most commonly seen with post-inflammatory hyperpigmentation. So the patient conditions where there might be use of topical medications for various inflammatory conditions, and post-treatment response there might be increased dermal melanin pigmentation. Sometimes both epidermis and dermis both can be involved in post-inflammatory hypermelanosis, and there might be epidermal melanin increase along with the increase in other pigments. Now these pigments can be the red color pigments or the black color pigments, which might sometimes confuse if the patient is having tattoos, or it can be due to arsenic, mercury, bismuth, and so on. Okay, so these are some of the conditions of hyperpigmentation. The disorders of hyperpigmentation, as we had discussed earlier, these are the freckles, capillary spots, lentigo, solar lentigo, Becker's nevus, post-inflammatory hyperpigmentation, and fixed drug eruptions. All these are all responsible where there is a circumscribed pigmented lesions. Sometimes there is diffuse dermal melanocytosis, which is associated with systemic disease, Peutz-Jeghers syndrome. It can be associated with conditions of Graves' disease, etc. So coming to the entities of circumscribed pigmented lesions, the first entity is the freckles, which is usually tiny macular lesions as seen in this picture over here. There are discrete tiny macular lesions which are located in the sun exposed areas and are predominantly noted in fair skinned people. Now the lesion biopsy, if it is taken, it can be noted that there is increased activity of the melanocytes. So the number of melanocytes are not increased, but there is increased activity of the melanocytes, which is usually towards the flattening of the retina ridges, and pigmentation is seen. So this is how the freckles can be noted, which is indicated by the hyperactivity of the melanocytes. The next entity is Becker's nevus. Becker's nevus, or the pigmented hairy epidermal nevus, which is an hematomatous proliferation of smooth muscles, hair follicles, and melanocytes. These are usually unilateral and are restricted to the shoulder, trunks, and back. Microscopically, these will have these papillomatous projections with smooth muscle proliferation and increased melanin pigment along the papillomatous projections. Next is the melasma. This is usually the mask of pregnancy, or most common finding which is noted in patients who are having chronic sun exposure or under any tropical or under the use of any oral contraceptives or during pregnancy. These are restricted to the malar area, to the face, and to the sun exposed areas. So this will be the macular lesions which are seen in patients with melasma. And if we do a biopsy in these patients, this can be seen that there is slight increase in the melanin along the basal layer, along with increased melanin pigment incontinence in the upper papillary dermis. Next comes the post-inflammatory hyperpigmentation. This post-inflammatory hyperpigmentation is responsible for increased melanin pigment. This pigment may be localized in the epidermis or in the dermis, and entry conditions such as lichen planus, atrophic dermatitis, psoriasis, and contact dermatitis, when under treatment, might develop this hyperpigmentation, and it will persist for few months and gradually resolve. The fixed drug eruptions. Fixed drug eruptions, patients who are having history of intake for NSAIDs or antibiotics or barbiturates are might have these drugs reactions, and these drug reactions initially are in the form of macular lesions, as can be seen over here, and on continuous chronic exposure they will be having these edematous lesions with well circumscribed margins, and in the late stage there might be deep pigmentation. This is also identified by the microscopic features. In the microscopy also we will see that there is increased melanin and melanocyte pigmentation along the basilar layer, along with pigment incontinence, which is seen in this picture over here. There are these pigment deposits within the melanocytes and the macrophages in the papillary dermis. Capillate spots or axillary flecking. These are the capillate spots or the CAMs are the most hallmark of neurofibromatosis 1, and these are more prominent in patients who have fair skin, and they can be easily identified by the lesions. These lesions should be at least more than 1.5 centimeter in diameter, and the number should be more than 6, along with the other features of systemic manifestations, gliomas, skeletal deformities, and list nodules, which can also be seen in patients with neurofibromatosis. So these patients are not affected by the exposure to UV light. Rather, these are located in the body covered area. So these are the lesions which will be located along the axillary region and in the back, which are not the sun exposed sites. And this was the criteria which I had told. Next, coming to lentigo simplex or simple lentigo. These are well circumscribed macular lesions of 1 to 5 mm size, and they are uniformly brown or dark in color. The most important finding under the microscopy is there is the prominent rete. So these are the elongated bulbous elongated rete which are seen, and we can see that the melanin and the melanocytes are more predominantly localized towards the tip of the rete and the lateral borders. So that is how we differentiate this from freckles, where there was not so significant elongation of the rete, but here in this lentigo simplex or simple lentigo, the similar will be the appearance for solar lentigo, where there is the presence of this elongated rete, and the bulb of the rete will be having the prominent melanocytic proliferation. This is the summary of the circumscribed pigmented lesions which we had discussed just now, and we can see that the freckles, there is melanocytes are increased with increase in the number of dendritic processes. Lentigo and solar lentigo, there will be increased basilar melanocytes. Capillate spots won't have much increase in the basilar melanocytes, and these are usually associated with neurofibromatosis 1. Becker's nevi is basically a smooth muscle hematomatous proliferation along with the increased proliferation of the pigmented cells and hair bulbs. Systemic diseases such as syphilis, malaria, diabetes can also produce pigmentation in the skin. Peutz-Jeghers syndrome has also been seen to have hyperpigmented macular lesions in the lips and the oral mucosa, along with hematomatous polyps in the small intestine. These patients usually have a high risk of breast cancer and gynecologic malignancies. So this is the pigmented lesions in a patient with Peutz-Jeghers syndrome. We can see that there is multiple buccal mucosal pigmentation in the lips and in the buccal cavity. There will be these polypoid polyp-like structures in the intestine, and there will be the biopsy findings showing the smooth muscle proliferation along with the polypoid-like structure of the polyps. Next, coming to acanthosis nigricans. Acanthosis nigricans is seen as in patients who are preceding to diabetes or overweight and obesity. These macular lesions, which are dusky brown in color, can be noted along the neck, axilla, groins, hands and feet joint spaces. So this is the characteristic finding in these patients. My biopsy will be revealing the features of papillomatous projections as seen over here. These are the papillomatous projections and increased basilar melanocytic activity which can be seen in this picture. So the next group of disorders after we have completed the circumscribed pigmented basilar lesions is the dermal melanocytes. So till now we were restricted to the epidermis only. Now we will be moving into the dermal melanocytosis. So the dermal melanocytosis causes can be the Mongolian spots, the nevus of Ota, nevus of Ito, and blue nevus. So coming to Mongolian spots, Mongolian spots are most common along the buttocks and the lower backs in newborns. These are like a just like a blanket-like appearance which are present over whole of the trunk or lower extremities, and the bluish color macular lesions is because of the Tyndall effect. So this is where there is scattering of light and it gives the appearance of a bluish color look. And these usually resolve after 2 to 10 years of age. So there should not be any treatment required for these patients. Then we can differentiate the Mongolian spots from the nevus of Otto, nevus of Ito, and blue nevus. Ideally, these are usually unilateral location in cases of nevus of Otto and Ito, whereas blue nevus is also unilateral. The site-wise, it is characteristic that Mongolian spots are newborns and they are usually in the lumbosacral region, whereas the nevus of Otto is along the first and second trigeminal nerve, as seen in this picture over here. These are the localized to the face, forehead, and into the sclera, whereas novus of Ito is in the upper extremity, that is the shoulder and the upper arm. Although these all are benign lesions, and histologically, if we see, there is usually the melanocytic proliferation, which is restricted to the upper half of the papillary dermis, and these are usually the mature looking melanocytes which are present. The next group of disorders includes the acquired melanocytic nevus. The common acquired melanocytic nevus is the junctional nevus, the compound nevus, halo nevus, recurrent melanocytic nevus, and okay, so coming to the common acquired melanocytic nevus, it's also known as a mole, and as we all know, these are all less than 6 mm in size. So the most important finding of a benign lesion or a melanocytic nevus is the size of the lesion. If it is macular, papillar lesion, or it's a dome-shaped lesion as seen in this picture over here, and sometimes they may be polypoid or papillomatous in appearance, but the color is uniform. That is, it may be brown, gray, or black, but it is having a uniform color. So these are some of the features which should be noted while the patient is examined or while giving the gross, so that it helps us in reporting. So the common acquired nevus can be having junctional activity. So as I told you, the nevus cells always proliferate in a nest-like pattern. So this is the nest-like pattern which is seen, and they are located either in the lower border of the dermoepidermal junction, or they are located in the intraepidermal region. So this is the patterns which can be seen for junctional nevus. Junctional is when there is activity along the junction between the dermoepidermal region. Whereas compound nevus is when there is activity in the junction, that is, this is activity is located in the junction, and simultaneously there are the melanocytic nevus cells which are dipping down. So we call it as a compound nevus. And the acral nevus, which can be identified as stratum lucidium, which is prominent over here. Along with that, there is the nevus cells which are present along the bulbous reterigeous and in a lentiginous pattern. So this pattern, when the nevus cells are arranged in a linear pattern along the basement membrane, we call it as the lentiginous pattern. Then comes the dermal nevus, where the lesion is not touching or in association with the epidermis. So the lesion is purely in the dermis. These lesions are well circumscribed lesions. You can see that there are two tongues of papillae of the reterigeous which are projecting and are circumscribing the dome-shaped lesion or the dermal nevus. This dermal nevus usually has the maturation phenomenon. That is the one which I discussed in the earlier slides regarding the type A epithelioid looking cells, which is seen over here. These are those epithelioid looking cells. And then we have the type B cells or the nevus cells, type B type, which are the lymphoid-like appearance, and the Swannian differentiation, which can also be seen. So sometimes this Swannian differentiation of the nevus cells might get confused with a neurofibroma or an other neural tumor. So we have to do some microscopic complete examination along with few markers if required. So the activity can be in the junction, which is called the junctional nevus. It can be in the junction and dipping down into the dermis, we call it as the compound, or the dermal nevus, where the lesion is totally restricted into the dermal region. So ideally, all these are round to oval with a small lesion, which is usually less than 6 mm in size. So that is the most important finding. However, junctional nevus will have nesting at the tip of the retinages. So if you remember the picture which I had shown earlier, there was nesting at the tip of the retinages. So suppose this is the retinages. So the nesting will be seen in the junctional activity. This is what we call it as the nesting-like phenomenon at the junction between the dermoepidermal region. This same feature can be seen in compound nevus, whereas dermal nevus is a nevus which is totally aloof from the retinages or from the epidermis, and it has no connection with the epidermis. So this helps us in identifying the lentiginous spread in cases of junctional nevus, whereas dermal nevus will show the features of zonation or the maturation. And the point to note is there is minimal or no nuclear pleomorphism. Mitotic activity is usually not seen, and the zonation or maturation phenomenon is retained. So these are the examples of the dermal nevus in the top slides. But if we remember the earlier slides where I told you that there might be papillary lesions or verrucous lesions, and the nevus cells will be restricted to the papillae or to the verrucous projections. And that is what can be seen in this picture over here, where the papillae are showing the presence of the nevus cells. So we call it as the papillomatous dermal nevus. Apart from the features of clinical appearance of a papillae, there might be stromal response. The stromal response can be in the form of desmoplasia. Desmoplasia is when there is a predominant collagen and lymphocytic infiltrate, which can be identified in this picture. The stromal response is a reaction is seen along with the nevus cells, which are also present. So this is how we identify the desmoplastic type of nevus. Sometimes there might be lipomatous metaplasia, which is infiltrating into the nevus cells, or there might be angiomatous changes. Though these all are the findings which will help to identify that it could be having some metaplastic change. The next entity in the acquired nevus includes the balloon cell nevus. As the name indicates, there should be balloon cells. What are these balloon cells? These are basically the progressive vacuolization of the melanocytes. So the melanocytes sometimes undergo vacuolization, and the criteria to call it as a balloon cell is the presence of these balloon cells with at least more than 50% of cell population having clear foamy vacuolated cytoplasm. So this is how the balloon cells will look like. This is a cluster of balloon cells. Sometimes they might have pigmentation, but these always confuse with the pseudocybes, and they also will have the vacuolated cytoplasm. But here there might be the presence of melanin and the presence of the cells which are present. So this has to be characterized and identified as balloon cell nevus. Then comes the halo nevi. Halo nevi is characterized by the presence of a circumferential halo. This circumferential halo is usually seen in the nevi, and when this pattern is noted, it is usually during the summer when the patients or the persons are exposed to sun and the adjacent skin undergoes tanning, and as a result of this, there is a circumscribed region which is becoming more prominent in these patients. So we can identify that it's a halo nevus, but even if it's an halo nevus, there is no loss in symmetry. So both the lesion, if the lesion is practically divided into two halves, there is maintenance of symmetry. Along with that, there will be the presence of the mononuclear cells and presence of lymphocytic infiltrate. So halo nevus will have presence of lymphocytic infiltrate also. Apart from that, there will be absence of mitosis, and there will be little atypia or absence of atypia, which are the features which has to be differentiated from a melanoma, where if we compare halo nevus with a melanoma, the size of the halo nevus is usually less than 6 mm compared to melanoma, which is more than 6 mm. There is maintenance of symmetry, there is no atypia, mitosis, or effacement of the retinages. That's how it will be excluded from melanoma. This is the picture of halo nevus. We can see that there is a clear area of which is circumscribing the nevus, which is located over here, and under the microscopy there will be a brisk infiltrate of lymphocytes along the nevus cells. So that is the feature, and these are usually CD8 cells which are present infiltrating into the nevus cells. Sometimes there may be the neural nevus, which I was already discussing. So the neural nevus is because of the presence of this cytoplasmic waviness or spindling of the cells. This is known as the type C cells, and they might get confused with a neurofibroma. So the differentiating features of a neural nevus from that of a neurofibroma is, as we all know, that it should be pigmented, whereas a neurofibroma are usually non-pigmented apart from the variants of neurofibroma. The neural nevus will have the type C cells or the neurotized cells, whereas neurofibroma will have predominantly Schwann cells, perineural cells, or fibroblast and collagen. Neural nevus will have a nesting pattern, which is a characteristic feature which is absent in case of neurofibroma. The nesting pattern is actually located at the dermoepidermal junction. And most important is, if IHC is done, the panel of markers, which includes factor 8, myelin basic protein, glial fibrillary acidic protein, and LEUK7, these all will be negative in case of neural nevus, and they will be positive in neurofibroma. Melan A will be positive for neural nevus. S100 will be positive in both, but the pattern of positivity will be different for neural nevus, where there is intense positivity along in a globoid-like pattern in neural nevus compared to the waviness in case of neurofibroma. So this is how we can differentiate a neural nevus from a neurofibroma. Then comes the recurrent melanocytic nevus. So the recurrent melanocytic nevus is a type of lesion which occurs in patients who had previous excision of a nevus, and recurrence of this occurs the recurrence is basically a misnomer. We can consider that it is because of the incomplete excision or the incision biopsy which was incomplete, as a result of which now the melanocytic cells have, or the nevus cells have started proliferating again. So this is the previous area of biopsy, and there is small redness and erythematous region and scare formation. This scare is identified in the biopsy also with the presence of this dermal collagen and fibrous tissue which is present in the papillary dermis. But along with that, there is the presence of these nevus-like cells in a nest-like pattern along the dermoepidermal junction. So you will have the dermoepidermal junction nevus cells along with the presence of scar tissue, which will be an indicator. And these lesions usually occur after 6 weeks to 6 months of previous incisional or excisional biopsy. The next group of disorders after the acquired lesions will be the benign melanocytic nevus. This includes the atypical nevus, congenital melanocytic nevus, page nevus, and the combined nevus. Now, these are the nevus like the melanocytic nevus which have a chance or progression to malignancy in future. So it has to be carefully examined. Coming to atypical nevus or dysplastic nevus, we can see that these are the types of atypical nevus which can be seen in a macular-like lesion, and there is some glistening cobblestone-like appearance which is noted over here in the biopsy, and there is some degree of atypia, but the color is almost maintained. So there is some degree of asymmetry, but the color is almost maintained, which is somewhat golden brown in color. Now, these atypical nevus can be of low grade, intermediate grade, or high grade. The progression from low grade to high grade is based on architecture of the lesion or based on cytomorphology. So the architectural patterns which can be seen in low grade tumors or low grade atypical nevus are the lentiginous proliferation, which I was saying that the tumor cell or the nevus cells are proliferating in a linear pattern along the dermoepidermal junction. We call it as the lentiginous pattern. There might be little or no pagetoid spread, and there will be the elongation of the retiridges, but the maturation of the cells is maintained. That is the from epithelioid to lymphoid to Swannian differentiation will be maintained. Whereas in case of grade atypical nevus, there is prominent pagetoid scatter and expansile lesion of the maturation of the cells will be noted. Cytoarchitectural features are also an important finding. The cytoarchitectural features will include discontinuous atypia. What do you mean by discontinuous atypia? Is when the lesion is having some cytomorphological atypia, but it is not uniformly present throughout the whole of the microscopy. But in case of high-grade atypical nevus, there will be continuous atypia. This continuous atypia is gradual progressing from the discontinuous type, and the atypia can be in the form of nuclear enlargement, nuclear pleomorphism, prominent nucleoli, and hyperchromatism. So these are some of the findings which are by which we can identify a low-grade atypical nevi which is progressing into a high-grade atypical nevus, but the size of these atypical nevus are usually less than 6 mm in size. So this is the picture of an atypical nevus, which you can see that there is nesting of the nevus cells over here, but there is some degree of atypia in these nevus cells which are present over here. So these are slightly larger, or maybe 1.5 times the larger to that of the basal cells which are located here. So this is one of the feature of atypical nevus, that the cells are gradually attaining atypia. The cytoplasm is also showing haziness and duskiness in this nest of tumor nevus cells. Gradually, as these nevus cells undergo further degree of atypia, they will attain the epithelioid and the spindle-shaped pattern, which is located, which can be identified in the this picture over here. So these are some of the features which can progress from a low-grade atypical nevus to an high-grade atypical nevus. The next entity is congenital melanocytic nevi. This is most common in the head and neck region, and they are usually the macular to brownish black lesions which are located in the skin surface, and they have junctional, compound or dermal pattern. So the nevus in case of congenital melanocytic type will be either junctional, compound or dermal. However, based on the size of this congenital nevi, it can be categorized into less than 1.5 centimeter, 1.5 to 20 centimeter, or more than 20 centimeter. So the most important finding in or to differentiate between a small congenital nevi from benign medium size to giant congenital nevus includes the involvement of the dermis. So small congenital nevus is usually restricted to the reticular dermis or upper half of the reticular dermis, whereas the medium size and the giant congenital nevus can extend into the subcutaneous tissues. So they will have the pattern. So this is the picture of a small congenital nevus, and in this small congenital nevus, as I had already told, that the lesion or the nevus cells will be having the zonation and maturation phenomenon, and they will be restricted to the upper half of the papillary and the reticular dermis. So this is predominantly restricted to the upper half, and they have a tropism towards the adnexal structures, towards the nerve bundles, towards the blood vessels, as seen in this picture over here. But in case of giant congenital nevus, they can be having the septal and lobular type of panicular pattern of infiltration, which is seen in this picture over here, where the nevus cells are seen infiltrating in a septal-like pattern along with some amount of lobular pattern, which is seen. So the difference between the congenital nevus types and the acquired nevus, which we had discussed earlier, we should remember that in case of acquired nevus or the small congenital nevus, there is usually junctional activity and it is involved till the papillary dermis. But the medium size and the large size congenital nevus will have involvement of the deeper reticular tissues and the subcutaneous tissues, as shown in this table over here. The next entity is the Spitz nevus. Spitz nevus has various synonyms, and it was actually the size of the lesion, which is usually less than 6 mm in size, and the type of cells which gives the term Spitz or Spitzoid. So which is because of the presence of the spindle-shaped cells or the presence of the epithelioid-like cells, which gives us this name of Spitz nevus, along with the person who had first identified or named the term Spitz nevus. Grossly, this Spitz nevus will have a symmetric lesion. So this is the well circumscribed, sharp bordered, symmetric lesion which is shown. And if we divide it into equal halves, they will be the mirror image. There is no difference in color. So that's uniformly brown, black in color. And this is how it's identified that the Spitz nevus is having low grade features or benign. These Spitz nevus can be dome shape as shown in this picture over here, and they will be well circumscribed from both ends by the presence of these spindle shaped to epithelioid like cells with a wavy cytoplasm. So these are the epithelioid like cells, and they will be having the polygonal like appearance also. So this is the features which are characteristic of Spitz nevus. But along with the presence of epithelioid and spindle shaped cells, there might be the presence of these homogeneous eosinophilic structures, which we call it as the Camiano bodies. So these are the homogeneous eosinophilic structures which are seen, are usually located at the junction of the dermoepidermal region. So this is the near to the junction of the dermoepidermal region, we will find the homogeneous eosinophilic structures which are the Camiano bodies. Sometimes IHC can also be done when there is a suspicion that it could be a case of melanoma. So in these scenarios, IHC will be helpful, and the use of HMB45 and Ki67 can be used. So as I had already told, that the nevus cells can be positive for HMB45, but these are only restricted to the epidermal region, and the deeper dermal tissues are absolutely negative, which indicates that this is not a malignant lesion. Had the whole of the area been a positive, diffuse positivity for HMB45, which would indicate that these are malignant. So this that main tumor tissue is, or the nevus cells are absolutely negative. Only the cells which are located in the dermoepidermal junction are positive. This could be the keratinocytes. And the proliferative index, which is identified by the Ki67. The Ki67 proliferative index is important, and in this case there were few cells which are positive, but the overall proliferative index was less than 2%, which is the criteria for calling it as benign. So the low grade or low risk of malignancy, the proliferative index would be less than 2%, whereas if it is slightly high risk, the grading is based on 2 to 5%, 5 to 15%, or if it is more than 15 or 20%, we call it as the chances of malignancy increases with the proliferative index increase. Coming to the atypical features in case of spes nevus, atypical features in case of spes nevus can be in the epidermal portion, or it can be in the dermal portion. So the intraepidermal features of atypia in case of spes nevus will be either in the lentiginous pattern or the junctional activity, and there might be asymmetry, poorly circumscription, and the shoulder phenomenon. So these are some of the features which might be noted in cases of spes nevus which are progressing or having features of atypia. Now, what is shoulder phenomenon? Suppose there is a nevus-like cell, a cluster, which is a spes nevus, which is located in this dermal tissue, and this nevus is now proliferating and extending up to the rete. So it will give us a shoulder-like phenomenon. This phenomenon, when it is extending and reaching up to the rete and spreading beyond its width, it is known as the shoulder phenomenon, or the lateral extension of the intraepidermal component. There, apart from the epidermal features, there might be cytological architecture variation in the form of pleomorphism, enlargement, and presence of nucleoli. The dermal features which can be present also includes the presence of increased cellularity. There is a deeper extension into the deeper tissues, and the lack of maturation. So lack of maturation is also an important finding which might indicate that the lesions are progressing towards malignancy. There is a grading system which has been used for the identifying the degree of atypia in spes tumors in cases of children and adolescents. So these grading systems can be used in order to group them into low risk, intermediate risk, or high risk based on the age of the patient, the size of the lesion, whether it is less than 1 centimeter or more than 1 centimeter, whether there is involvement of the subcutaneous fat, ulceration, and the number of mitosis. So the mitosis is also an important factor. Mitosis should be always be looked under the 40x view, and we should always identify the hotspots which are required for counting the number of mitosis. So these are some of the variants of spes nevus. There is a huge list of variants, but few to show over here. We can see that these spindle shaped or epithelioid cells not only are located in the dermoepidermal junction, but are seen extending towards the stratum corneum, which is the pagetoid spread. Sometimes there might be desmoplastic response in case of compound spes nevus. There might be this dermoplastic response which is shown over here, and there might be the presence of pigmentation and a starry sky-like appearance which is shown, or the sunburst-like appearance which is shown in this picture of a dermatoscopy finding of pigmented spes nevus, where we will find the presence of these nests of spizitoid cells which are located in the dermoepidermal junction. Next, coming to blue nevus, as the name indicates, blue nevi is because of the Tyndall effect. So when there is the lesion which is located in the extremities or in the wrist or in the buttocks, and having this bluish-like tinge, the size of the lesion being less than 1 centimeter, circumscribed, symmetric, bluish black or bluish gray in appearance, along with the presence of dense, intense activity of melanin and melanocytes in the dermal zone, which can be seen over here. There is dense intensity of melanocytic proliferation and melanophages, which are seen extending into the dermal zone. These cells may be wavy, as can be seen in the lower picture. However, there are some other variants of blue nevus, which include the sclerosing blue nevus and the amelanotic sclerosing blue nevus, where there might be absent of melanin pigment in these nevoid cells. There might be some other variants also of blue nevus, which will have intense and very strong presence of melanin pigment, which can be the epithelioid blue nevus or the cellular blue nevus. And these all have high risk of progression to melanoma, and hence they should be completely excised while the grossing or the biopsy is being done. Coming to the last group of disorders, which is the most important, and that includes melanoma. Melanomas can be having a radial growth phase, which is non-tumorigenic, which includes the superficial spreading acral lentiginous, lentigo maligna, and the unclassified ones, whereas the vertical growth phase tumors, which includes the nodular melanoma, desmoplastic, and the neurogenic types. So these are the various groups of melanoma, and melanoma is associated to be, is noted to be having the maximum amount of skin cancer related deaths in United States. In India, the incidence of melanoma is approximately less than 0.5%, but there is a gradual record of increase in the number of skin cancer related melanomas in India also. The various factors includes the type of nevi, if they are typical or atypical, the presence of sun exposure and UV light radiation exposure, the presence of family history of melanoma in the skin and in the family, and also the immunosuppression. So these are some of the risk factors which may be associated with melanoma. Now, the WHO classification 2018 for skin tumors has classified melanoma into the various groups based on the genetic mutations. It can be based on the cumulative sun damage effect. So the cumulative sun damage effect can be low cumulative sun damage effect, or it can be high cumulative sun damage effect, or it can be classified based on the radial growth phase and the vertical growth phase. So superficial spreading is the most common type of radial growth phase non-tumorigenic melanoma. Apart from that, there will be lentigo maligna, which is the in situ type, and the lentigo maligna melanoma, which is the invasive type. We also have the acral lentiginous melanomas, which includes the palmoplantar, the subungual, and the mucosal melanomas. And there may be the other group of melanomas, which includes the melanomas in the breast, genitals, and etc. Similarly, vertical growth phase melanomas are the most tumorigenic, and the most common among the vertical growth phase melanomas includes the nodular melanoma. Apart from it, there may be the amelanotic melanoma or the desmoplastic melanoma and the neurogenic melanomas, which can also be seen. There are some rare variants of melanoma also, which are also noted. So, to grade it as melanoma and to differentiate it from a benign lesion, the best way is to identify and characterize the lesion based on the ABCDE. So the ABCDE is basically for A stands for asymmetry, where a benign lesion or a normal lesion will have symmetrical lesion, whereas a melanoma or a cancerous lesion will have asymmetry in its borders. The border is regular, as seen in this the nevus cells or the nevi. Whereas in case of cancerous or malignancy, there will be irregular borders, which is seen over here, or ragged borders, which can be noted. Then you have the color of the lesion. It is uniform brownish or blackish in appearance compared to a cancerous lesion, which will have this difference in color. So there will be a spectrum of colors from brown, black to gray in appearance. The size of the lesion, it is usually less than 6 mm in diameter for a benign lesion, whereas in case of cancerous lesions, it is more than 6 mm. Exception for this fact is the small melanoma, which is usually less than 3 mm in diameter. And the evolution of the lesion, that is, the lesions are rapidly evolving. There was an initial small lesion and this persists for years together. That indicates that it's a benign lesion. Whereas if the lesion is evolving rapidly, then there is chances that it could progress to malignancy. So melanomas can be differentiated from the benign nevus. So the difference is basically in the size of the lesion, as we had already discussed, and the circumscription. These melanomas are poorly circumscribed and asymmetry, and there will be the presence of the loss of rectal ridges, parasitoid spread of the tumor along the dermoepidermal junction or in a linear lentiginous pattern. Similarly, the dermis will have the involvement of high cellularity, variable depth infiltration. There might be features of mitosis, atypia, and ulceration. So these are some of the various features which will be noted in case of melanoma, and these are usually absent in case of benign nevus, or they are not seen. Now coming to the different gross morpho features which can be seen in case of melanoma. This is a picture where you can see that this patient had a congenital nevus which was slightly less than 1.5 centimeter, but over adjacent to the congenital nevus there is a melanoma which has been developed. It's a nodular type. There is a variation in the color of the melanoma which can be seen in this picture, and asymmetry. It's somewhat grayish over here, and there is blackish tinge in this area with asymmetry. Sometimes there may be the small melanomas which are usually less than 3 mm in size. And melanoma also can be in situ, as seen in this picture over here. This is a macular lesion with irregular borders and variation in color from brownish black in appearance. Then they can be having the invasive potential, which can be seen in this picture. In this case, it was a case of invasive melanoma. Sometimes the melanoma can also develop adjacent to the in situ component also. So this staging of melanoma or grading of melanoma is done based on two factors, that may be the Clark's level of invasion, or it can be based on the Breslow's thickness. So these are the two grading systems which are followed. What happens in Clark's level of invasion is whether the tumor is restricted within the epidermis, we call it as the stage 1. If the tumor is restricted or moving up to the papillary dermis in the upper half of the papillary dermis, it is stage 2. If it fills the full of papillary dermis, it is the stage 3. When the tumor is reaching into the reticular dermis, we call it as stage 4. And when it is entering into the subcutaneous tissue, it's called as stage 5, based on the Clark's level of invasion. Whereas Breslow's thickness is graded based on the thickness, and this thickness is always measured from the top layer of the granular cell layer. So this is the topmost layer of granular cell layer, and this is the point from where the thickness is measured, and the thickness can be less than 0.75 mm for grade 1. If it is 0.75 to 1.5, it is grade 2. If it is 1.5 to 2.5, it is grade 3. If it is 2.5 to 4, it is grade 4. And if it is more than 4 mm, it is grade 5. So that is how the Breslow's thickness is graded. Now the Breslow's thickness is most important because based on this, the staging of the tumor is done. So this is the CAP protocol reference which I have utilized, and we can see that in this picture, the measurement has been done from the granular cell layer, which is the topmost layer in the just underneath the stratum corneum. From the layer, the deepest point is the point where the thickness is measured, and this is the tumor thickness which can be noted. But if there is ulceration, or if the epidermis is ulcerated or denuded or eroded, then what has to be done? In case of ulceration, the thickness is measured from the base of the ulcer to the deepest point of the tumor tissue. So this is how the measurement is done in patients where there is ulceration. So the epidermis may be intact or may be ulcerated, but the staging is T1 to T4. So T1 is less than 1 mm thickness. Again, T1 is divided into T1A and B, which is based on the presence. When there is the granular layer present, it is T1A. When there is ulcerated and the lesion is measured from the base of the tumor, and it is up to the deepest point, you call it as T1B. Similarly, T2 is for 1 to 2 mm thickness. T3 is 2 to 4 mm, and when in T4, it is more than 4 mm. And all these have been graded based on presence or absence of the ulcer. Sometimes the melanoma can be restricted into the within the dermoepidermal junction, and this is the melanoma in situ. Now the melanoma in situ, the tumor cells or the melanocyte, typical melanocytes may proliferate in a linear pattern, or the melanocytes may move up in a pagetoid pattern. So these are the two different patterns which can be seen. Sometimes there may be nesting of the melanoma cells within the dermoepidermal junction. So then it is also restricted by the in situ component. The melanoma can sometimes have these cameo-like bodies, which was also seen in cases of atypical space nevus. These are those homogeneous eosinophilic bodies which are restricted to the upper papillary dermis. So this is the dermoepidermal junction and the upper papillary dermis. This is up till this point that these cameo bodies are noted. Next comes the in situ component with pagetoid spread. So this picture over here is trying to show the pagetoid spread. We can see that there is no infiltration into the dermis, but there is upward extension of the tumor cells. This upward extension of the tumor cells or the atypical melanocytes can be seen, and the features to call it as pagetoid melanocytosis is the presence of these atypical pagetoid-like melanocytes, which are seen extending upwards into the superficial stratum corneum, and they are having an buckshot like appearance. So this is how the buckshot like appearance look like. Suppose this is the basal layer and the tumor cells are seen spreading upwards. It gives us this buckshot like appearance, which is noted over here. There may be the lentiginous spread also. In case of lentiginous spread of melanoma in situ, the tumor cells are seen in a lentiginous pattern along the dermoepidermal junction, but they are not dipping down. So that is how you identify the lentiginous pattern of melanoma in situ, where the tumor cells are seen, but they are restricted in a linear pattern. However, there may be mixed patterns, which includes the nesting also. So these tumor cells, as I was discussing earlier, they are arranged in a nest-like pattern at the junction of the dermoepidermal area, but they are not invading deeper tissue into the deeper dermis or to the papillary dermis, and they may be also associated with lentiginous or pagetoid spread. So as seen in this picture over here, here we can see that the tumor cells are having the pagetoid spread into the stratum corneum. And in this case, it is the lentiginous spread of the tumor cells, which is seen over here along the rete. Melanoma can be differentiated from a nevus also. And in order to differentiate a melanoma from a nevus, based on histomorphology is the gold standard, but use of proliferative markers can also be done. It includes the Ki67 and the P16. So in case of nevus cells, P16 has a strong intense positivity compared to the melanoma cells, which are variable irregular positivity. And you can also do the Ki67, where the nevus cells will have proliferative index less than 5% or less than 2%, whereas the melanoma cells, the proliferative index will be more than 20%. The conventional melanomas, which we had discussed earlier, it can be the superficial spreading, the nodular, the lentigo maligna, and the acral lentiginous. The point to be noted over here is superficial spreading is the most common, and it is the good prognosis because it is restricted to the upper papillary, to the lentiginous pattern, and it has low risk of cumulative sun damage effect. Whereas the lentigo maligna and the acral lentiginous are also seen in the sun exposed areas, and they may have the palpable or flat shaped lesions as seen in this graph table. Now coming to the histopathological features of superficial spreading melanoma, the superficial spreading melanoma usually has a pagetoid spread, that is, they spread in the upward direction towards the stratum corneum, whereas lentigo maligna and acral lentiginous will have a lentiginous spread, which I had shown in the previous slides. The superficial spreading melanoma usually has the epithelioid-like cells, whereas the lentigo and acral lentiginous may have the spindle and epithelioid-like cells. Now, the most important finding is the presence of dermoplasia and neurotropism, which is seen in cases of lentigo maligna and acral lentiginous melanomas, whereas these are uncommon in the nodular and the superficial type. Superficial spreading type is the most common to develop from the precursor nevus. The precursor nevus can be the atypical nevus or the congenital melanocytic nevus or the blue nevus or the halo nevus. These, if they have degree of atypia, they can progress to superficial spreading melanoma in the future. This is a picture of superficial spreading melanoma, where the color is irregular. We can see that here there is a blackish appearance and the grayish to the brownish appearance, asymmetry and irregular borders with pagetoid spread of the melanoma cells into the papillary, into the stratum corneum. Nodular melanoma has a dome shape like lesion, and the presence of these bizarre looking atypical cells and melanocytes with pigment also. We can do the proliferative index marker here. Ki67 was done, and we can see that all the red color are the proliferative index of positive for Ki67, and it's more than 20%, which indicates that it's a melanoma. Next, coming to the lentigo maligna, the melanoma in situ, where the tumor cells are proliferating in a lentiginous pattern, and these patients have solar lentigo or solar elastosis. The solar elastosis is a feature which is seen. So these are the common in the sun exposed areas on the body, that is the face and the arms, which are the most common site for lentigo maligna. The lentigo maligna is the in situ, whereas the lentigo maligna melanoma is the invasive component which can be seen. Then is the acral lentiginous. The acral lentiginous is either in the palms, sole, or in the buccal mucosa, and it can be in the subungual region also in the nail beds. So these acral lentiginous melanoma again can have the lentiginous pattern or the nesting pattern, though these are also showing the features of lentiginous pattern with high degree of atypia, nucleopleomorphism, mitosis, prominent nucleoli, which can be noted. There are also variants of melanoma based on the cell type or the architectural pattern, which are basically melanoma, but the difference is based on the cell types. The type of variants of melanoma can include the desmoplastic melanoma, where there is absence of melanin and presence of a desmoplastic collagenous stromal response, which is seen. And there might be the angiotropic melanoma, which wherein the melanoma cells are present, so encircling the blood vessels, which can be highlighted by the immunostains for melan A or CD31 markers. Primary melanoma has to be differentiated from melanoma which has undergone metastasis to distant sites in the cutaneous places. So the difference between a primary melanoma of the skin and the melanoma which has metastasized to the skin is the primary melanoma is usually restricted to the epidermis and the dermis, whereas melanoma which has undergone metastasized to the cutaneous sites will have subcutaneous involvement, which is an important finding. The primary melanomas will have shoulder phenomenon and a pagetoid horizontal spread, which I discussed earlier, whereas in case of melanoma with metastasis, there will be the absence of shoulder phenomenon, but rather the dermal component will be more wider in appearance. The primary melanomas are usually larger than 0.4 centimeter, whereas metastatic melanomas will be less than 0.3 centimeter. Then there is marked pleomorphism and atypia in the primary melanomas compared to the metastatic melanoma deposits, which will have less degree of pleomorphism. Primary melanomas don't have intravascular usually have variable intravascular component, whereas the melanoma with metastasis will have more degree of intravascular involvement. So this is how we can differentiate a primary melanoma from a melanoma which has undergone metastasis at the cutaneous sites. That's a panel of markers which are available in WHO, and these markers can be used for the detection of melanoma based on the proliferation and differentiation index. And if we see this slide over here, we can see that if HMB45 was done for a nevus, so a typical nevus or space nevus, we can see that the positivity is restricted to the upper half of the upper half of the dermis, and this is the area where it is positive, but the deeper tissues are totally negative. Whereas in case of melanoma, there will be HMB45, which will be diffusely positive throughout the tumor tissue. In case of nevus, the proliferative index or Ki67 is very low, whereas in case of melanoma, the proliferative index is very high, as seen in this picture over here. There is a study which has been done correlating P16, Ki67 and HMB45 as a battery of markers which can be used for differentiating the atypical nevus or the premalignant lesions from the melanoma. And this method can help in identifying the possibility of risk of malignancy in the patients who are having atypia in the nevus like cells or the atypical nevus or the congenital nevus. So coming to the conclusion, we have the most important is the correlation between the clinical and pathological findings and discussion with our dermatologist so that we are aware of the findings which the clinician has noted. The proper handling of the melanocytic lesions or the tissue samples, so it has to be properly handled. There should be sufficient margins which should be taken for the during the course of the biopsy. So if it's a benign lesion, at least 1 to 3 mm margins are sufficient, but if it's a malignant lesion or an in situ component, say at least 0.5 to 1 centimeter margin has to be taken circumferentially. Increased tumor thickness, level of invasion, ulceration, microsatellites, angiotropism, and vasculolymphatic involvement are associated with poor prognosis. Vessels thickness, as we discussed earlier, is the most important factor for staging of tumor. IHC has its role. S100, HMB45, melan-A, microophthalmic transcription factor, all can be used, but they have their own limitations of being positive in other lesions and other tissues. So IHC should be judiciously used along with histopathology being the gold standard. So these are some of the references. And thank you for the patient hearing.
Good evening, everybody. Am I audible?
Yeah.
Good evening, everybody.
Yeah.
I will co-host on behalf of Kiran sir.
Okay, sir.
I congratulate today speaker, Dr. Santosh sir, for covering our topic, the topic comprehensively and enlightening us about this melanocytic lesions. Sir has covered he has covered the spectrum of lesions, and he has not only covered, he has made the subject topic very lucid, and concepts were very clear, and it will be very helpful for our postgraduates. It is up to the postgraduates to utilize this lecture, which will be available even in the WhatsApp. He made very lucid and also palatable. Thank you very much, sir.
Thank you.
Due to next coming on to the question and answer session, I apologize due to time constraints and also due to technical difficulties. We are not able to have this question and answer session. Yeah, we have got alternate plan, B plan. What is that B plan? You can post the questions by WhatsApp group to us, and we will post that to intern to sir, and it will be mailed. Please also provide your email. We will post the answers through email. We will respond. Okay. And now I will also have the privilege of proposing the vote of thanks on behalf of Kiran sir. I thank Dr. Santosh sir for accepting our invitation and enlightening all of us, all the virtual audience as such. Then Dr. Kiran sir for hosting this major event for us, which is the first event for our association. And also I thank our association executive body members for the solid support what they provide, what has been provided for us to host this session. Not the least, I thank all the virtual audience for joining us to enjoy this visual treatise presented by Dr. Santosh sir. Thank you very much. You can also you will be given feedback forms. Please do not forget to give your feedback so that we can improve this program and we can continue this program further with more improvements. Thank you very much. I will end this session. Over to Vijay Bhaskar sir. Unmute sir.
Thank you, Dr. Kumar. I thank profusely Dr. Santosh for his lucid presentation. A spectrum of lesions has covered, and as you said, it's very useful to our postgraduates. Once again, thanks, Dr. Santosh. I hope we will have such a beautiful meetings in the future. Okay, thank you.
Thank you very much.
Thank the organizing persons, IAPM State Chapter, for giving me this opportunity. And it was basically focused on the point that our PG students, whoever are doing the grossing or examining the slides or screening the slides, should be able to catch all these points at the ground level, so that when it is coming to the reporting table, that we are aware of all these findings and some clues which will help us in differentiating common lesions. So that will be an helpful factor. So that's how it goes. And thank you everybody for the patient hearing.
Thank you, sir.
Thank you, sir.
Thank you. Shall we end, sir?
Yeah.
Thank you, sir.